Okay, so now we'll be transitioning over to have a conversation about anything that we've missed from this discussion so far of the first 6 themes. And so I'll be turning it over to Lucia Hindorff and Wendy Chung.
Thanks, Anastasia. So this session will be a little bit different in the sense that Wendy and I will be presenting some slides and we'll have a discussion and then we'll turn it over to the next panel. So we've covered an incredible amount of ground in the past day and an hour or so. Wendy and I have compiled topics that we heard from the discussion so far that we thought were raised, but perhaps not expanded upon in terms of NHGRI's role in establishing the forefront of genomics. So we're going to go through those ideas quickly and then open up for discussion. So.
Thanks, Lucia. So if we could have the first slide. Oh, thank you. Okay, so I hope you can read this. So we've divided these into sections, as Lucia was saying. Some of them we heard something about. There are some topics that I heard nothing about, or at least almost nothing about. So I specifically wanted to draw those out, and these are not a lot of prepared comments, but some things that we can have discussion about. So some of these are my pet peeves, and some of you who know me already know some of these pet peeves. But so when it comes to, for instance, we've heard about VUS and ACMG classifications. I personally think we've got categorical classifications right now. I really would like to push for us to be quantitative in terms of more transparent and actually have some probabilities associated with these things. And I think that's the type of thing that patients and providers who are non-geneticists can actually get their heads around better than what we do now. And hopefully that just helps us in terms of transparency. And hopefully it's data-driven as we're doing this. Another thing in the diagnostic side, and I can say because I deal with rare diseases, this is something that I find all the time, is that laboratories who don't necessarily know a gene very well are guessing a lot in terms of what their interpretation means. And there's a lot of data that are still on the research side, in some cases not published. And if there were a way of being able to have the networks that connected the gene experts or disease experts in certain cases with the diagnostic laboratories, it's basically phone a friend. And it happens on an ad hoc basis, but I think there are ways of being able to do it more systematically and hopefully therefore be able to get useful information that is evidence-based, but to the patients who need it without having to wait for the series of publications that unfortunately may take in some cases years until they do see the light of day. But I think that's important, and I think it becomes increasingly important as treatments are available specifically. And so as I think about how to prioritize things where there is a treatment available, I think it's really important to prioritize those genes and those conditions. Another thing we've heard about a little bit, but I would just sort of emphasize the need for scalability for this is being able to iteratively reanalyze our data over time. So whether this is done centrally, whether this is done within laboratories, but to be able to do that. And I'll put a shout out specifically because we've been doing several focus groups and surveys in terms of hearing what the community needs are for this. We're hearing over and over again that this needs to be centralized. That is that, for instance, all of the rich data that are in ClinVar are very helpful, but as the ClinGen expert groups are actually doing expert curation and changing variants and therefore have increasing validity associated with that, there needs to be the infrastructure computationally to be able to then go back and churn those data specifically and push out those revised reports. And the more that can be centrally driven and free and accessible is what we're hearing over and over again, is what it's going to take in terms of real implementation for that. So whether that's through the ClinGen, ClinVar sort of environment or something else, I'm not going to necessarily prescribe, but at least we've started that as a community. So I just emphasize that I think we can do more with that. One of the other things that we touched briefly about, but I just want to emphasize again from what we hear about patients, there are common diseases, there are rare diseases, there are environmental factors. At the end of the day, patients and their providers want that integrated risk analysis. And so in terms of being able to come up with a PRS score, that's wonderful, but that's only a small piece of the puzzle. And so I think as we're thinking about this, and it's even things that are highly penetrant like BRCA1 and 2, increasingly we do know there are common variants that are modifying that risk. And at the end of the day, people want to know about their real-time risk as well. They want to know about their near-term, what's my 5-year risk, and importantly, can you give me any biomarkers or any feedback to tell me where I am along that risk continuum? And I think as we're able to do that better, people are going to be making hopefully better decisions. We didn't talk about it, or we talked about it a little bit in terms of neonatal rapid turnaround testing. We really didn't talk about prenatal testing at all at this meeting. And so I just want to sort of point that out as an area that we've missed. And I would argue that in terms of being able to be actionable comfortable with this information. I can tell you with working with our neonatologists, they would love it if we could give them a game plan with the baby coming out the chute, being able to know what to expect, having even delivering at the right hospital, having the parents being able to get their heads wrapped around what the therapeutic options are and plan that, rather than, I can tell you there's a lot of PTSD for parents of sick newborn babies, and so being able to alleviate some of that, I think, is hopefully something we could do, and it is possible to do that rapidly now in the prenatal setting. With this, I intentionally divided out diagnostics and therapeutics, but I want to emphasize that to me, we've really got to get over the diagnostic phase. It's really our future is in therapeutics, and we didn't emphasize that enough, but I do think these are very much yoked. That is that you can't start the right treatment if you don't have the right diagnosis, and as we have treatment options, we should be doing that diagnostic phase much more rapidly for those conditions. And so as we're doing this, one of the things that I look at and I hear all the time is that many of the pharmaceutical companies that are trying to do therapeutic trials can't even find the patients that they need for their trials. And so again, it sort of pushes us one step back, but we can't even get to the starting line in many cases without being able to diagnose or have diagnoses for many of those patients with rare diseases. And furthermore, for many of those clinical trials, you really need to be able to start those treatments early in the disease process. If we're later in the disease process, many of those conditions are irreversible or at least not readily reversed. And so it's a little bit of the chicken and the egg, which is that we may not get many of those therapies over the finish line to FDA approval unless we've identified, dare I say, even pre-symptomatic individuals in these cases. And so we are going to need to have ways to be able to do that. And I'll just point out, many of you know the story of spinal muscular atrophy, but that was absolutely sort of, for me, the use case in terms of demonstrating that necessity. So as we do this, we've been talking more about it today, so I won't emphasize it too much, but when we think about genomically informed clinical care, our teams are really very multidisciplinary as we're thinking about these, and so therapeutically, we also need to continue to think about that. They are going to go in different dimensions, especially as we get into gene therapy, and in some cases, even bringing in surgeons in certain cases to be able to deliver some of those. So with this, I'm just going to shift now in terms of patient subgroups and patient-centered research. So within this, I do hope we've got many different rare diseases, at least when I think about in the medical genomic space. One of the things I see in dealing with many of the family groups for these rare diseases is there's some economy of scale that I wish we could realize, in the sense that many of these patient groups are trying to establish their natural history studies, trying to get, I think of them as toolboxes, but resources in terms of, for instance, cell lines, databases with genomic variants, infrastructure in terms of survey instruments, outcome measures, these different things. But rather than having each of these thousands or hundreds and then thousands of groups reinvent the wheel and come up with this, there is certainly a need for an economy of scale in terms of having very easily accessible, easy to use for families, bite-sized pieces where they can be able to put in data, and then importantly, share the data, get that information back so that they're learning in real time. And I would emphasize for many of the rare diseases, especially the international need to do this. And of course, that makes it a little bit more difficult with the data sharing internationally, but it's ultimately, I think, a catalyst that could be quite helpful. With this, we talked a bit about this yesterday, but in terms of patients as agents for change, really how to study the behavioral change itself, what actually motivates behavioral change, what are the catalysts and enablers for doing that. Some of the other interesting things, at least I can see working with the patient groups, is interesting issues of data ownership and who owns that and how can they readily navigate some of that space. And again, many of the patient advocates that are coming up with this, again, I think there are economies of scale for helping them to realize that and to be able to own that. And finally, as we think about this, just being able to be rigorous in terms of doing that and measure outcomes and being able to figure out how we can do better by patient engagement, real true partnership in patient engagement, but again, being able to assess how it is that we're doing with those. So let me turn this over to Lucia.
Okay, and we had a second slide that had more to do with sort of higher level, broader level, systems level factors. And so I think the question here is that NHGRI doesn't have unique ownership of any of these spaces, but we certainly could partner with folks and stimulate a lot of research and other activities in these areas. So starting with health systems, yesterday we talked about the idea of a data exchange or a safe harbor for genomic data and health data, and making those data durable. So something that we're born with, the genome is something that we're born with, but what the genome means at each point in our lives is dynamic. And so what are not just the conceptual underpinnings of this, but what are the policies and practices and infrastructure that we can take advantage of to make such a safe harbor? We talked a little bit about scaling up yesterday. I don't know that we were all necessarily in consensus about what it looks like to scale up genomic medicine, but one question might be what data, research, resources, et cetera, are needed to scale up genomic medicine in a meaningful way. We talked a lot about collaborations and partnerships. So where should NHGRI fit into international data commons? Data sharing is such a huge area, and genomics has had some early successes, such as the Matchmaker program in stimulating collaborations and data sharing among international groups. So can we use that as a model for additional data sharing internationally? And then we talked a lot about partnerships and mentoring relationships between more experienced and less experienced healthcare systems. And then finally, we did talk a little bit about study designs which could embed clinical trials into existing studies, perhaps not waiting until we had the gold standard evidence of clinical trials before implementing genomic medicine, but really thinking practically about how we could design some of our research consortia or other efforts to embed these clinical trials into existing studies. And then finally, one overarching question, perhaps that might be helpful in framing what else NHGRI could think about is what won't get done if NHGRI doesn't do it. I think we've identified a lot of areas where NHGRI could have a hand in stimulating, partnering, funding, but really one thing that might help us focus is really to think about what the world would look like if NHGRI didn't do a particular thing. And so I think we can turn it over to discussion here. We'd love to hear from the broader group.
Bob? Oh, sorry, I'm Mike first.
Mike first.
So one big idea that we haven't talked about, maybe it's one of the grand challenges, is implementation of evidence of protection from the genome. So if you think about the polygenic risk scores and you think about some of the other discoveries that are being made in genomics, we're finding, on the polygenic risk scores, everybody's looking at the far right, where there's the risk, but on the far left, there's the protection. And so there's not a 50-year-old in America that wouldn't welcome the chance to not get colon cancer screening. But if we could prove that in an implementation case, that things like that, there's enough protection that we'd be able to tell a subgroup of the population that they don't need some screening that we currently do, or that we save the healthcare system money, I think it would be powerful. There's no reason we can't do that in the next 10 years.
Bob?
I like Mike's idea. This has been hit on a couple times, just want to get back to it, is again, sequencing technology getting better and less expensive will serve the idea of scaling up population-based screening.
Yeah, I mean, just following on that, I think Katrina sort of pushed a little bit into made a screening probe in one of your slides, if I remember correctly, where you're not proposing testing asymptomatic individuals. And I haven't heard that much about that here. Is that a thing that NHGRI should push into in a significant way?
One of the things that related to that question that I have been wondering about is, given the accessibility of direct-to-consumer sequencing and the fact that most genetic tests are done outside of the clinical genetics workforce, there are already many algorithms that digest genetic information and return guidance, which people are using in many different ways. And this is a completely unregulated area. And so, as the experts, what could we do to influence that system, which is already up and running in the absence of regulatory oversight?
Juan?
So another idea that I haven't heard anyone talk about would be some sort of biobank or cell repository that you could potentially, for example, when children are born, save cord blood or placenta, get cells from that. because the sequencing technology we're using right now might not be the sequencing technology we want to be using 5-10 years from now. And so if you have cell samples from a large cohort, then you can then revisit with new technologies, rather than having DNA samples that you may not be able to use with the next generation techniques, such as that need, let's say, high molecular weight DNA or longer fragments of sequencing.
Hi, so under the topic of study design, I think one topic that hasn't come up is how we can incorporate sensors and mobile technologies into collecting rich behavior and lifestyle and environmental data. And so, in doing that, also consideration of data quality in doing that, so we can learn from well-collected data from others' research where it's collected using surveys or some other designs as well.
Bob, I think you had your hand up next.
Yeah, just to answer your question about population screening of asymptomatic individuals, and I think it's going to happen, and it's already happening in certain scenarios, and there's a ton of implementation research to be done around it. There's a ton of questions about exactly what to report in asymptomatic individuals. A question of people who are getting testing on the basis of family history of early cancer, things like that, versus a person who doesn't have family history and gets a screen. And are the differences in penetrance really that different in those, and why? Scientifically, what's the basis for those differences? There's just a huge slew of questions that can be asked in those scenarios.
We have an online question next, and
So yes, we have an online comment talking about developing bold ideas with stakeholders who will end up using research findings, particularly payers and health systems. Having them at the table while we develop RFPs may ensure that our findings directly inform practice, payment, and policy. Several Medicaid payers have told us that they don't know what to cover in terms of genomics. They were burned in the past when they covered things. They don't feel like they should have, and there's not enough information about non-white populations to guide their decisions.
So going back to the asymptomatic and public sequencing, I think, it is already happening, and I would prefer it happening in a more regulated space like NHGRI with some LC components in there. So some research into what's needed in the, ethical, legal, and social aspects of people getting this information without any context of a clinic or a disease or a doctor or someone to talk to. I think that would be really nice because those are completely different issues than your diagnostic issues.
Yeah, I wanted to go back to your question as well, Les. Yes, I would love to see NHGRI studying that for many of the reasons that have already been stated. And in addition to some of the penetrance risk, medical outcome, and ethical, legal, social issues, I think we also need to be looking at psychological impact, at best way to communicate, at best way to deliver, at who and how is that information provided, at how we figure out when those situations are that you've gone through 3 antibiotics, so you need to bring in the immune expert. So.
Another topic that I feel that we haven't spent very much time on in the past 24 hours has been privacy. And as we think about moving to mobile health and doing deeper phenotyping, we really enter into a place where we can no longer maintain this charade of de-identification of data. And we, I think, as a collective profession, need to think much more deeply about what does that mean as we do research, because these databases, especially for rare disease, really in order to be impactful, will need to be international. And so how do we how do we bring people along, recognizing the risks to their privacy, recognizing that there is no de-identification or anonymous contribution to research that's going to be possible, I would argue now, but certainly very shortly. And how can NHGRI fund research and acknowledge this dawning reality, at the same time preserving what we can about people's rights and protections.
Patrice.
I think at a meeting I heard Terry say that the NHGRI's domain involved nucleic acids. Is that sort of the limit?
It certainly includes that. I think where we see, obviously, it sort of diffuses outward, and so we're most aligned with nucleic acids, but the impact of those is also something that's in our mission.
Okay, so one of the things I think we haven't talked a lot about is the integration of genomics with other omic technologies and what that means for diagnostics.
Do you have something more specific around that? I mean, I don't, that's a broad area.
It is very broad. And so I think part of my interest is in terms of how we're integrating different diagnostic technologies. I think is really important over the next 10 years. I think we're going to start to see more of those come to the clinic. But the methodology for doing that, sort of the metabolomics field, is not where the genomics field is, but I think the integration of that needs to be approached in a systematic way. And a lot of the things that we do in genomics could inform, for instance, the interpretation and things like that across that. With the other omics, but not being at the table together, I think hinders the translation of that in the next few years, or it could be a barrier.
I had both a highly specific example that has been on my mind this week, which is RNA sequencing as adjunct to DNA sequencing, and whether that increases quality. So the higher level topic is around quality and whether there's a quality problem with the tests that we're offering, whether the traditional ACE framework still holds for the tests right now, whether once we get to the point of defining our desired diagnostic outcomes, which is really, I think, the framework in which you think about it, where are the potential risks with our delivery system right now to not achieving those outcomes or to bringing about adverse outcomes as a result of quality issues.
I think one of the things about sort of that circles a lot of the questions that have been asked today already has to do a little bit with the way that the field is shifting, where we've started off and really in the last, I would say, 10, 20 years, been in a phenotype-first environment where you've identified a rare disease phenotype and you are looking for the nucleic acid cause of that phenotype. And so then you go phenotype first, you go genotyping second, trying to identify that cause. We're moving rapidly into a phase where we're going to be genotype first, where we are going to have cohorts of individuals where we don't have a clinical phenotype yet, but we already have their complete or as close to complete genotype, meaning that we potentially have their whole genome sequence. Then the question is, it's always going to come down to high quality data on both sides of that equation. So when you are in a genotype first environment where you have the whole genome sequence, it's incredibly important to be collecting high quality phenotype data from these quote unquote asymptomatic individuals, because at the end of the day, no one is truly a wild type, right? Everyone has something. And so I do think that it's, as we think about genomics in a preemptive screening sort of phase, we do have to think about investing in tools that actually allow us to phenotype more specifically so that we can continue to do high quality genotype phenotype research.
Yes.
I think that as we start looking at, doing a genotype first approach, as you mentioned, we're probably going to start observing more variants that fall really in between the complex and Mendelian world. And there's some vocabulary that exists in the Mendelian space to deal with this. Omen will have, say this disease is multifactorial or a risk variant, but still the language of saying a variant is pathogenic or benign might be insufficient for the type of relationships that we see between genotype and phenotype in the future. And I wonder if anybody has any thoughts on how to address that.
So I would just go to, I love quantitative metrics in this. So I love things like odds ratios, relative risk, penetrance, disease risk in the next 5 years. I think the more we can get to the quantitative measures, the better we are.
I also, in addition to the quantitative, which I 100% support, the other thing with is that there's no discussion of protection, right? It's like it's bad or neutral. And I know you can always flip it around and talk about the other one, but it's weird sometimes when it's
right.
Right.
And I actually thought that was part of what Mike's point was, is that we haven't really talked about resiliency or protective factors as well. And so, that's part of what we need to be doing.
Online, Jody?
Yes, we have 2 online comments. So one second. Suggestion for public health challenges deserve more consideration than I heard until now. I heard genetic epidemiology, newborn screening, and biomedical informatics, but other disciplines typically seen in the School of Public Health should be mobilized for this amazing conflation of sickness care and disease prevention and screening. A grand example of public health genetics is national newborn screening. NIH has no National Institute of Public Health, so perhaps NHGRI should seize this rare opportunity to lead the charge within its expertise of genomics. And I have another comment, suggests that NHGRI support methods development for using real-world evidence to understand the impact of genomic sequencing on patient outcomes, including in the screening context, since RCTs are infeasible for many questions related to health and economic outcomes.
No. Before we go to Mark, I would just add to your list, Wendy, to quantitative metrics are posterior probabilities. Williams.
Thank you. This builds on Wendy's comment as well as the online comment about outcomes, and that is that we need to develop a standardized set of outcomes that we're going to be looking at across programs, because one of the challenges we have is that we have lots of different funded programs, but if we all define our outcomes differently, we're not going to be able to synthesize the information that's learned from different settings. An example of how the NIH has actually invested in this was research around the patient-reported outcome measures, the PROMIS measures, which are now required to be used if you're doing funded research for NIH that involves patient-reported outcomes. And so I think some investment in defining a set of outcomes related to genomic medicine could pay dividends in terms of being able to do combinatorial data analysis going forward.
I'd like to follow up on Wendy's comment about building a network where you could phone a friend for a gene expert. I think that's a great idea. I totally endorse that. I also wanted to share a couple other thoughts on that. So, I think we all know that the Gene Matcher has been insanely successful, and that's one example of connecting networks together that I think Wendy was also referencing. I also want to point towards networks that combine, again, basic science expertise with clinical expertise. So there's the RDMM network in Canada that I think they've done a good job of connecting basic scientists with clinicians. There's the RDCRNs here, funded by the NIH. And then I also want to make a pitch for an idea that comes from a colleague, Shinya Yamamoto in Baylor, something called Model Matcher, where it would be a basic science expert who has built a model of a genetic disease who would then connect with the clinicians. So I think there's some room to grow there in terms of building networks of expertise.
Just say one other thing before we end, building on that comment. I've seen personally within the Gene Matcher program that there are a few, but not, I don't think, enough gene experts that actually would have a lot to learn from the human phenotypes that we see associated with this. So any way we could to be able to populate those and basically making matches between clinicians and clinical experts and basic science experts, I think would be a good thing.
So I just wanted to add on Wendy's comment about patient engagement and metrics around that. So patient engagement in joining research studies, as well as engagement in their care, and metrics to monitor those, to just kind of splitting it out into those two areas.
I do think think this comment about a shift from phenotype-based to genome-first approaches is particularly relevant. And I do feel like we're trying to force like a square peg into a round hole a lot of times, specifically around the semantics about pathogenicity. And so, because a clinician thinks pathogenic means disease-causing, and like if someone has high blood pressure, I don't say that's pathogenic. I say that's a risk factor. And so I do wonder if there needs to be a separation of those two, where one set of variants may actually be disease-causing, and there has to be some arbitrary metric of what the penetrance has to be. But another set of variants actually would be put into a risk like a risk framework. And Wendy, I totally agree about a lot of our work has been, okay, can you make a better risk model that integrates common, rare variants, lifestyle variants, and so forth? And the short version is, of course, you can, and it will improve predictive value. But no one wants to make a prediction that no one's going to use. And so I guess my question is, have you interacted with professional societies like in IBD or breast cancer or other places where they actually really want a new predictor that integrates genetic information such that, like, if we build it, they will want it and use it?
So I'll put out there, I personally think breast cancer is actually the farthest ahead in terms of actually clinically implementing this, and for whether we got into it for the right reason or the wrong reason, but we have highly penetrant genes, moderately penetrant genes, polygenic risk score, and we've had lots of good models in terms of knowing about the lifestyle factors or the lifetime factors. And so there are people that, and we do have sample sizes that are large enough to now start to estimate these. So personally, that's where I think we're farthest ahead in terms of doing this comprehensively, and women care a lot about the risk of breast cancer. So in terms of public awareness and public demand, if you will, I think that's a relatively well-organized group, and it's a common condition that affects a lot of people. So I don't know. Personally, I think we're going to learn from that community.
Thanks. I haven't heard very much in the last day or so on how NHGRI could work more collaboratively with the All of Us research program. Several items on Wendy's list, I think, are already at the forefront of that program, and particularly on the patient side. And it's clear that when the NHGRI strategic plan is launched, the data will be there for a lot of programs to do, a detailed analysis of genotype, phenotype relationships, and so on. So I'd encourage us to really think about leveraging that important resource. And maybe it's also relevant to include the Million Vets program as well, even though that may be a harder program to collaborate with than All of Us.
Bob? Here you go.
Freaking out. Sorry. So one barrier that I've run into in terms of some of the materials that the consortium projects have produced is that the websites that they do to disseminate their products actually don't get someone else there when they go there. So it's more like they're developed as a side thought, or that they're developed for their collaborators that they're constantly on the phone with anyway. So somebody else coming in and say, I want to make use of the Monarch Initiative materials that they have developed, or their ontogenies, it's completely opaque. So I think that's something that could be done better in the future. I don't know, I don't have an answer as how to make that happen, but that's something to shoot for.
Time? Right. Thanks for this group.